Hello and welcome to this video on atrial fibrillation from the RCSI Perdana Department of Family Medicine. I'm Professor Anthony Cummins. This is what we're going to look at in this video. We'll have some learning outcomes for you and then a series of aspects to do with atrial fibrillation, not just its diagnosis and so on, but its management and risk assessment in order to ensure it is correctly and promptly managed, plus also looking at choices of medications nowadays. With the onset of the novel oral anticoagulants, we now have a choice between those and warfarin. Your learning outcomes for this presentation are as follows. Having viewed this, you should be able to clearly describe the pathogenesis and the mechanism of development of atrial fibrillation. You should also be able to demonstrate how to diagnose it. And you should be able to outline a management plan for a 75-year-old woman with long-standing type 2 diabetes mellitus who now presents with new onset atrial fibrillation. Atrial fibrillation is a common disturbance of rhythm and probably one of the most common serious disturbances of rhythm. It may be episodic or paroxysmal or persistent, and is characterized by a rhythm that is irregularly irregular, which is confirmed by ECG, showing narrow complex QRS and absence of P waves. How does it arise? Well, there are various theories about this, but one consistent theory is about sinoatrial node dysfunction. Your sinoatrial node is your pacemaker, and that drives the beat, so to speak, and then sends impulses through the atria to the AV node, through which it goes down in through the His system into depolarized ventricles. And normally this is how it works. Both atria are have the impulses going through and are depolarized, and then it goes onto the AV node. In atrial fibrillation, there's some initial dysfunction in the sinoatrial node, which then leads to a chaotic and non-structured depolarization towards the AV node, so that only some electrical impulses reach the AV node. It's not hugely prevalent in under 60s, but if you look at what happens as people get older, by the time they hit 80, it's 8 times more prevalent. And then it's also associated with a greater stroke risk by 5-fold. If you have atrial fibrillation and you're at this age group, then your stroke risk is increased 5 times. And of those who have a stroke in these elderly age ranges, a quarter of them are associated with atrial fibrillation. TILDA is the Irish Longitudinal Study on Aging, which is an ongoing cohort study, and this has looked at atrial fibrillation among other things. What it showed that the prevalence overall of atrial fibrillation documented by an ECG was 3.2%. This is much less, however, in those under 60, but significantly higher in these age 80 and over. And of interest, 40% of those who actually had atrial fibrillation were completely unaware of it, and this figure was greater in these aged 65 to 70. Clearly, this is a big challenge for us in terms of patient education and awareness. The causes depend on whether it's acute onset or chronic AF. If it's acute, there's usually a precipitant, and the most common precipitant would be an acute pneumonia. And often these issues here they occur simultaneously. So it may be an older man who's a heavy drinker, develops a pneumonia, and the combination of high alcohol intake and the pneumonia precipitate an acute burst of AF. And we also get it from vascular events like myocardial infarction, pericarditis, pulmonary embolus, and also thyrotoxicosis can precipitate it, and so it can arise also post-operatively. In just over 10%, there is no discernible cause found on investigation, and this is often described as lone AF. But typically it will be associated with coronary artery disease, hypertension, especially those who have LVH or left ventricular hypertrophy on an ECG, patients with cardiomyopathy, and people with valvular heart disease. In particular, mitral and especially mitral stenosis, because of the increased pressure in the atria and enlargement of the atrium, precipitates atrial fibrillation. It is classified according to whether it's acute or recent onset, paroxysmal, persistent, long-standing, persistent, and permanent. And generally speaking, if it's acute like this, first onset, you may refer those patients for cardioversion, but we'll discuss that later under management. For paroxysmal AF, these are bursts of atrial fibrillation that terminate within 48 hours usually, and in fact usually much earlier than that, but they may take up to 7 days. If it's lasting more than 48 hours, then these patients should be put on anticoagulation because the likelihood of spontaneous conversion thereafter is low, and it is usually recurrent. Persistent AF is AF that does not terminate and lasts more than 7 days. This will usually require either in-hospital cardioversion or drugs to cardiovert, such as amiodarone or dronedarone. This is also recurrent. Long-standing persistent is defined as persistent AF that has been continuously there for more than 1 year. By the time it becomes permanent, we've abandoned all hope of rhythm reversion, so rhythm control is not a major consideration at this point. Symptoms and presentation. They commonly will present with some or most of these: palpitations or chest discomfort, the breathlessness, fatigue, lightheadedness, syncope. They also present, however, with an event precipitated by the atrial fibrillation, such as a TIA or stroke, a mesenteric embolus, or acute severe heart failure. Quite commonly also it is found incidentally. The patient has no symptom, is found on an ECG, or is found on clinical examination and in a patient in whom you did not suspect it. So, for example, in a routine clinical examination for other reasons, or an insurance, medical, or health check. The diagnosis may be primary or secondary. In other words, if it's been due to some other precipitating cause, then you should also look for that. If there's no obvious secondary cause, such as thyrotoxicosis, anemia, recent sepsis, or valvular heart disease, and you would look for evidence of that clinically, but also you would listen for the murmur, the diastolic rumbling murmur of mitral stenosis, and also you may want to follow up that with an echocardiogram. If there's no obvious secondary cause, then you should check the pulse for rate and rhythm, check the apical rate in relation to the radial rate, check the blood pressure. It may be low if the patient is in rapid AF. Check the jugular venous pressure. Check the heart sounds and listen for murmurs, particularly mitral murmurs. Is the apex beat displaced? Is there clinical cardiomegaly? Are there signs of acute heart failure? In all cases, take a thorough history to find out as accurately as you can, is this new or is this old? Because if you decide which type it is, then that will dictate how you manage it. These are the ECG features showing an irregular rhythm, absent P waves, a normal QRS, and usually the rate is fast between about 100 and 140. You need to differentiate this from atrial flutter, which has a more of a sawtooth pattern, and the rate is usually faster. Here's an example of atrial flutter showing the typical sawtooth pattern on the ECG. Management. Effectively, what you have to decide, first of all, is it recent onset or not? If it is, then you must look for a precipitating cause. There usually is one. If it's recent onset and there seems to be no cause, then you need to admit for cardioversion. Clinically, if the patient also is hemodynamically deranged from it and compromised, so they've got hypotension, they're breathless and fatigued, and they're in fast AF, then you should also admit those patients. If it's not recent onset, you need to look at the risk factors that may be present. So this means taking a thorough history about alcohol consumption, coffee consumption, hypertension, thyroid disease, and refer for an echocardiogram to assess the state of the valves and the presence or absence of heart failure. If it's not recent onset, the next question is this chronic or recurrent? If it's intermittent, as paroxysmal AF, and infrequent, then you might consider no treatment or use the so-called pill in the pocket, which we'll cover in a moment. You need to give the patient adequate information about atrial fibrillation. You can get good sources from www.patient.co.uk or the British Heart Foundation on www.bhf.org.uk. If it's intermittent and frequent, then you may need to give sustained treatment with drugs like atenolol, sotalol, and if it doesn't respond well to that and the patient doesn't feel better over a period of a few months, then you may need to refer to cardiology. There are two main overall approaches, either rate control or rhythm control. For rate control, you should use, in preference to amiodarone, a beta blocker, atenolol, bisoprolol, sotalol, and you may need to use a calcium channel blocker in association with that if the beta blocker as sole therapy does not control the AF. For rhythm control, if it's appropriate, you should consider cardioversion and then aftercare to maintain the conversion back to sinus rhythm with amiodarone or dronedarone. There's a nice guidance, clinical guideline number 180, and you can look on it here with this link. You can also check on your iPhone or Android apps for the nice guidance app. And in outline, this is how atrial fibrillation, suspected atrial fibrillation is assessed. So you suspect somebody may have it, you check their pulse, and if it's irregular, you then do a 12-lead ECG. If that confirms absent P waves and the usual QRS, then and an irregular rhythm, then you would refer for an echocardiogram. Now, in many countries, you can do this directly from primary care. In Ireland, less so, and in England, it's a bit more possible to do that. Otherwise, in both countries, you have to refer to a cardiologist. So if you have somebody with confirmed atrial fibrillation, you may refer at any stage under the NICE guideline directions for specialist management. And then the patient will have undergo a personalized package of care. And this is aimed at preventing stroke and also controlling the rate and the rhythm. So for rate control, they suggest a cardioselective beta blocker such as bisoprolol or a rate-limiting calcium channel blocker such as diltiazem or verapamil. You should aim to maintain the heart rate less than 100 beats per minute. And only consider digoxin in elderly sedentary individuals. For rhythm control, this would be used if the patient is still symptomatic despite rate control or if rate control fails. This would be initiated by a specialist, and the options available are cardioversion, amiodarone, or cardioversion plus amiodarone thereafter, or if amiodarone doesn't help, dronedarone, atrial ablation, and pacing. The main point of treating atrial fibrillation is stroke prevention, so you need to assess two things. You want to assess the need for anticoagulation using the CHANCE-VASc score, and also determine the risk of bleeding with the HAS-BLED score. Let's now look at these. Oh, before we do that, let's look at the pill in the pocket. This is for patients who have paroxysmal AF that's infrequent. And they can use a beta blocker such as atenolol. In the past, they've also used drugs like propafenone. And you'll only consider this if they are infrequent and are not disabling. That there's no history of left ventricular systolic dysfunction, there's no background of valvular disease, there's no prior coronary artery disease, the systolic pressure is consistently above 100, and the resting heart rate is more than 70, and that the patient is able to understand when and how to take the medication. But if the episodes are very infrequent, then you could not really make an argument for taking medication every day to prevent something that might occur twice a year. Okay, let's go back to the risk scores, CHANCE-VASc and HAS-BLED. CHANCE-VASc is for assessing thrombosis risk. So the components are the presence or absence of congestive heart failure, hypertension, age more than 75, diabetes mellitus, previous stroke or TIA, previous vascular disease, including myocardial infarction, age over 65, and female sex. If the score is 0, you don't need to provide any anticoagulation. Aspirin is no longer recommended. If the score is 1, or if its score is 1, the choice is between aspirin and oral anticoagulant, but the jury has now moved towards oral anticoagulant only and not using aspirin at all. And if the score is 2, then it should be oral anticoagulant. And this could be a choice between warfarin and the NOACs, the novel oral anticoagulants. The HAS-BLED score is a way of assessing bleeding risk. So this takes into account previous hypertension, abnormal renal and liver function tests, previous stroke, episodes of bleeding, a very labile or chaotic INR previously, if they're over 65, and if they are drinking alcohol or taking other medication. If scores of more than 3 indicate a high risk of bleeding for which caution is advised. You shouldn't use the HAS-BLED on its own to exclude patients from the provision of oral anticoagulant treatment, but rather to highlight those patients in whom caution should be exercised because of a bleeding risk. So you may be a bit more careful with their INR control. How do you choose between warfarin and the newer drugs, and how do these work? Well, warfarin is a traditional vitamin K antagonist. It gives a 64% reduction in stroke in non-valvular AF compared to placebo, and the effect is reversible. It, however, needs lifelong monitoring with INR, and that needs to be controlled between 2 and 3 for 70% of the time in order to get this benefit. It interacts with certain things like alcohol and grapefruit juice, non-steroidal anti-inflammatory, certain antibiotics, clarithromycin, for example. The NOACs are novel oral anticoagulants, and they include apixaban, rivaroxaban, dabigatran, and edoxaban. These are either direct thrombin inhibitors, that's the dabigatran, or factor XA inhibitors. These are the other 3, rivaroxaban, apixaban, and edoxaban. They have less strokes than with warfarin, and the advantage also there's no monitoring of INR. However, there may be more GI bleeding from the trials that have been published. They haven't been assessed in patients with renal impairment, and more importantly, they're not easily reversible. These are linked to each of those drugs in the BNF for you to quickly recap. So how do GPs choose? How do patients choose? Well, there may be certain factors that might help in deciding between warfarin and a NOAC. If there's renal and hepatic dysfunction, if there are comorbidities, for example, prior history of GI bleeding, you have more GI bleeding with NOACs, and NOACs have not been tested in people with renal impairment. If there's polypharmacy and risk of interaction, for example, frequent antibiotics for COPD, people on NSAIDs, you may prefer a NOAC to warfarin in that situation. And also patient preference. Given adequate information from this resource here, Patient UK, they may decide which one they want to take, and that's their choice. You might look at the cost as well. If patients are paying for their drugs, NOACs are particularly more expensive than warfarin. You also want to look at likely adherence to INR checks if you choose warfarin. Is this person able to come for these checks? Is there issues with mobility, family support, transport, etc.? What about risk of falls? What about alcohol use and cognitive ability? Is this patient able mentally to manage with frequently changing warfarin doses based on changeable INRs? All of these things have to be put into the mix, and then a decision is made between the doctor and patient which they prefer. Here are some references for you. The Oxford Handbook, which is our textbook in the department. This is the paper edition, but this is the link to the online edition relating to atrial fibrillation. Quick Medicine is an app that you can download from iTunes or from Google Play. And also this is a link to the clinical practice guidelines on cardiovascular disorders, including atrial fibrillation, from the Ministry of Health Malaysia Clinical Practice Guideline Compendium. Thank you.